This holiday season, we're unwrapping something special for the direct primary care community. Hint Summit is coming to Nashville, Tennessee, April 8th through 11th, 2026. With the theme Healthcare in Harmony, unifying the direct care ecosystem, Hint Summit 2026 will bring together clinicians, employers, brokers, and partners to share ideas, build connections, and strengthen the movement that's transforming healthcare. Think of it as a gathering where the entire DPC community comes together to celebrate, collaborate, and chart the future. And as our holiday gift to you, use promo code MyDPCStory, all one word, for $50 off your clinician ticket. Give yourself the gift of inspiration, connection, and growth, and join the chorus of direct care leaders making healthcare brighter in 2026. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care. Dr. Emily Holt is joining me today, and she opened in October, and it is so exciting to be here in New Orleans. This is like one of the things that is the highlight of today, to be able to meet you and talk with you, but also in this town where you have lived and worked for many years in different roles. I would love if you could share with the audience, especially because we are at a time now where the quote, big, beautiful bill has passed, and it is now affecting communities like this lovely community that you live in and you work in. So can you tell us a little bit about what roles have you been in throughout the years that you've been in New Orleans?
Sure. Well, first of all, thank you for reaching out to me. I'm totally fangirling over here. And if it wasn't for things like your podcast, I would not have my own clinic. So thank you for what you've done for the movement. So yeah, I started when I graduated my residency in New York City, I moved to New Orleans with my two sons at the time and my husband. And I started working for a fairly qualified health center. And I fell in love with that population, honestly, that population of people who were very hardworking and needed health care. And that clinic was their safety net, really.
Yeah.
And I knew that I wanted to be that doctor for people for the rest of my life. When I had my third baby, I actually left that FQHC while I was on maternity leave.
Wow.
Because I could just tell that there's, before I quit, I was waking up at 4 a.m. to finish charting. And, after having been up several times breastfeeding one of the other ones and at night, it was not sustainable.
Mm-hmm.
And I was probably seeing between 22 and 26 patients a day at the FQHC. I really enjoyed the patients, but New Orleans is a pretty poor city in socioeconomic status. And so a lot of patients were coming from backgrounds of very, very meager means. And as many people who work at FQHCs can I probably identify with, I would spend a lot of my 15 to 20 minutes with a patient Googling or looking on Walmart's $4 list to help them figure out which 2 of their 6 medications they were going to purchase that month.
Yeah.
And so it felt a lot like I wasn't helping many people, but at the same time, I knew how important it was to be there and have places like that FQHC. So it really hurt to leave, but I also knew that I could not, it was not sustainable for me, my family, my mental health, my physical health. And so I left to go to a job that had a much better work-life balance. I was at the Tulane University Campus Health Center for 6 years. And I really enjoyed that job. I really enjoyed the patient population there. I realized that if I had even known what adolescent medicine was, I might have decided to do a fellowship at some point. It was just a fun population to work with, especially as a mom. I felt like all those students, those kids, those young adults were my kids.
Yes.
And I really enjoyed having a little bit more time to spend with them. And it occurred to me that so many students who came to college actually had very little education about themselves, their bodies, their health. And so this felt like a really fun opportunity to spend the time with them and educate them. So yeah, that's what it, and then I left to start my practice. So after that, so that's pretty much it. As a doctor, as prior to medical school, when I went to undergrad at Tulane University and I did a master's in public health there. I worked in between those two educations as an emergency medical technician for the city of New Orleans full time. I chose night shifts because you were guaranteed at least one gunshot wound per night. And I loved those adrenaline rushes.
Wow.
I actually thought I wanted to be an emergency room doctor. And, growing up, I didn't know any doctors.
Yeah.
There's nobody in my family is really in medicine. And so that's why I became an EMT. I wanted to know what it was like.
Sure.
And I thought for sure I was going to go into ER because it was just way too fun. All the trauma, not knowing what you were going to get called to next. This was back when we treated CHF exacerbations with IV pushes of Lasix.
Oh, man.
I seem to remember, I wasn't a paramedic. I was the emergency medical technician, so I didn't have the same skill level. But I remember when we coded patients that back then the paramedics would push drugs through the endotracheal tube. And, I learned so much and it was fun. Talk about dopamine rushes. But actually, I happened to be working full time when Hurricane Katrina hit the city of New Orleans. And that experience, I could talk for an hour about it, but the nutshell was I was stranded with my patients. They split, there were about 86 of us working for the city's New Orleans EMS, which at the time was called New Orleans Health Department. And they gathered us together the day of the storm and they said, okay, this is it. This is the big one. This is the storm we've all been expecting. It's going to be a direct hit, a category 4 or 5, a direct hit on the city. And we expect the city to be destroyed. And we expect communication towers to go down. And it's too late for people to evacuate.
Yeah.
And the Superdome, which is normally used as a what's it called? A shelter of last resort, is not going to be used as a shelter. So people will have nowhere to go. And so we know they're going to need help. So we're splitting you up into small groups and we're posting you throughout the city so that you can provide medical care. And I wound up at the Superdome. And so long story short, we got to the dome with all of our equipment after the levees broke and as the water started to rise. And we were stranded there with 6 feet of water surrounding the dome with the thousands of people who had come to the dome because they expected it to be a shelter.
Wow.
And it took 3 days for FEMA, the government, to show up with helicopters. And in that time, I had no choice but to get to know my patients.
Yeah.
All we did was triage. We took patients, the ones who needed to go first, and we didn't know what was coming because it's true all communications were down. So we didn't know if we should expect a boat or a helicopter. But we took the patients who we knew needed to go out first and put them in essentially a pile. We tagged dead patients. We separated the ones who could hang on a little longer. And being in such an environment of just desperate humanity. And I was in it with my patients.
Yeah.
I didn't have any food or water either.
Yeah.
Made me realize how important relationships were with the people I cared for.
Yeah.
And how much I wanted to know what had happened to them, what was happening to them. And so those long-term relationships were something I had never considered. And it made me completely change my trajectory in medicine. And I from then on, I decided I want to be a primary care doctor. I want to get to know these people. And I want to live my life with them, alongside them. Yeah. I don't want to treat them and street them, is how we would call it in the emergency room.
Totally. And that is, for the listeners, that is literally a pervasive term or phrase, and that is so realistic. But it also absolutely speaks to the person you are, that, you know, you are so mission driven to even become a physician, a primary care physician versus an ER physician, or, you know, somebody who is going to take care of people only in the acute stage. So here we are now, fast forwarding to 2025, this quote unquote big beautiful bill has passed. And like I mentioned in the beginning, we're already seeing the fallout of what happens when healthcare is not a human right, when human rights are not a human right, depending on the color of your skin, your orientation, your, you know, whatever it is. There's so much divisiveness right now. It's really, really a challenging time. And earlier we had a conversation about what happens when a clinic that is taking care of the patients who you know, the avatar of the patient who you used to care for, the person who goes to the FQHC clinic, when their care is being threatened because of funding, because of government funding can no longer be used for, you fill in the blank, you know, ism right now that is going on. What are you hearing from people in the community who are also with that same mission that you had, choosing primary care? What are they asking you in order to help these patients the same as you wanted to help your patients when you became a doctor?
Stay with us. We'll be right back. Running a direct primary care can mean wearing every hat. With Gusto, payroll becomes effortless. Unlimited payroll runs, automatic tax filing, contractor support, and benefits management all in one place. Imagine never stressing about W-2s, new hire forms, or compliance. Gusto handles it seamlessly so you can stay focused on your patients and not paperwork. If you're a DPC doc ready for a simple, reliable payroll solution fit for small businesses, check out Gusto and make payroll the easiest part of your week. The link will be in the show notes.
Yeah, I mean, you know, I think it's a difficult time right now in medicine because politics seems to have creeped in such a way that I've never seen it before. Huh. You know, literally today, a federal judge blocked the Trump administration's, I don't remember if it was an executive order, or I think it was, or it was, maybe it was a part of the big beautiful bill that said that Planned Parenthood could not take Medicaid funding. You know, that's been a really big issue in the Deep South because it's very hard for women in Louisiana to get good health care, full stop. I think we have one of the highest maternal mortality rates in the United States. And I think Mississippi might be number one on that list, and we're number two. And then to break it down further, Black maternal mortality is by far the worst. And it's extremely divided. It's a much bigger jump in terms of how bad it is than it is for white women. So when it comes to like, it kind of depends on what you're talking about, because it feels like there's different interests and physicians, they aren't necessarily all aligned. Yeah, sure. I mean, I'll just be totally honest with you. I'm a member of the Louisiana Academy of Family Physicians, a proud member of the Louisiana Academy of Family Physicians. We really don't, and I'm on the Legislative Advocacy Committee, and we really don't talk about the bills that are impacting women's health. We didn't even discuss the fact that Louisiana made mifepristone and misoprostol controlled substances in October of 2024. We were the first state to do it. That's not even something that Louisiana Academy of Family Physicians is vocal about. And frankly, it's because I'm sure it's because, I don't know, because no one tells me specifically, but they don't feel they have the support. And
Wow.
so when you ask a question like that, it's honestly hard to answer, because some physicians are out there saying, how can we support the patients who are no longer going to qualify for federally qualified health centers because they're undocumented, because of the big, beautiful bill that was specifically put in there to try to stop undocumented patients from getting health care. How are we going to serve those patients? Federally qualified health centers locally are very concerned about that. They are going to lose funding, and they can't make up the gap. Also, gender affirming care. There is one federally qualified health center that is still providing it, and everyone's kind of got their eyes on them and wondering, are they going to be able to continue?
Yeah.
Because there are even whole university systems in other states that have stopped their gender affirming care programs. So it's a very fluid situation, and large populations of people's healthcare are at risk.
Absolutely. And, I think about how there are probably listeners who are saying things that I definitely hear in California, like, oh, but that's not going to affect me. And that's absolutely not true, because as we see, if people are no longer working at jobs, it affects the supply chain. If people are no longer with access to healthcare, where are they going to go to the emergency room? And so when you actually have an emergency, you might be one of how many, if that hospital remains open, because if the Medicaid and Medi-Cal reimbursements are enough that they will stay open, who knows? So the complacency and the thoughts of like, that's not going to happen to me. When you see that happening, but you also see people in the community who are trying to look to the future and look with those types of situations happening, how to prepare to offer a pathway for people to access care, access healthcare, not insurance. What are the conversations that are going on in Louisiana?
Well, if you're not going to have the government funding like we were used to having, and that's pretty clear that that's going away, who can fill the gaps and how? And so just today, I had a conversation with an FQHC locally about, should we look for grants? Should we look for benefactors? Should we, and you and I were talking about, should I make a program for some people who are able to pay more, almost like that Robin Hood model that you mentioned, so that other people who can't afford it can pick it up. I have lots of service industry workers and who are members of my DPC. And just today I had two join, and they told me they each make about $16 an hour. They applied for Medicaid and they were told they don't qualify. They make too much, but they would have to pay $400 a month if they wanted a marketplace plan. They certainly can't afford that.
Yeah.
And so, the struggle is, where am I going to spend my time? How am I going to divide my time, and while also trying to grow and run a business, and reminding myself that I can't save everybody. And it sounds so trite, but it's something that I've struggled with since I was an emergency medical technician.
Yeah. And
so protecting myself is also part of this equation. My practice isn't even really profitable right now. And so you're asking the $1 million question, and a lot of people are putting their heads together to try to figure out how can we fill this gap. And I'm a little scared that I know we're not going to fill it for everybody, and there's going to be a lot of suffering.
Yeah. Yeah. And all of what you are saying is so true, and it's so painful at the same time because it is so true. And in my opinion, it is totally avoidable, because especially physicians like you and myself have been saying, we have to uncouple insurance from primary care for a very long time. There are thousands of doctors saying that, but yet at
levels of bureaucracy that are at, in different organizations, different levels of the state, government, et cetera. That is not the default, thought process of how do you do any healthcare without insurance it's not the default. It is definitely being more familiar because people are having to be creative. But I think that, yes, it is $1 million question, because if we could fix everything tomorrow, that would be fantastic. But unfortunately, too long, in my opinion, we have left this pipeline of medical students and residents to the wolves of corporate medicine. And like, I was there in terms of I was an employee. I didn't know how to do anything else. But when those are the only things that are presented to you, you're only taught codes and residency, and you're only taught the insurance system, it's almost like a learned helplessness. And when people like you and I are coming to the table to have conversations to try to fix things, definitely you've taken already a big step in being a part of a safety net. Tell us about your affiliation with Bija Clinic. Yes, I'm really excited about this. So Dr. Byron Jasper, who is a DPC physician in Baton Rouge, and he somehow figured out how to also start a nonprofit, Bija, and he brought me on literally as recently as a couple weeks ago as an affiliate to his DPC. And what I understand and the MOU that I signed said is that I, as an affiliate, can benefit from programs that are accessible to his nonprofit.
Mm-hmm.
Like, for example, I'm now connected with the public health department, so I now have rapid point of care HIV, syphilis, and hepatitis C tests that I can make available to anybody. And I also have access to his 340B pharmacy pricing. Now, the FQHCs in town also use this pharmacy. It's called Avita. And as I understand it, the larger the pot or the larger the nonprofit, the lower the prices get for the 340B pharmacy. And so if currently, I actually don't know if Dr. Jasper has other affiliates. I think he does. I think he has 3 other affiliates. Okay. But, as long as all of us are still quite young in our businesses and we don't have thousands of patients like these FQHCs do, the 340B pricing isn't going to look exactly like it would for an FQHC. Yep. But the more we grow together, the better the prices get, essentially, for our patients at the pharmacy. And the more we're able to help other patients who are in need. Yeah. And so that's one of, certainly Bija is mission driven.
Absolutely.
And I really respect that. And it's what I was drawn to when Dr. Jasper was talking to me about it. And so one of the things that he can do with Bija is any sort of donations to Bija or the money that comes from the 340B pharmacy can be used and distributed to affiliates for things like paying for memberships for patients who can't afford the membership fee, which is really exciting.
Yeah. And I think I love that we're talking about this. I love that we're together just brainstorming as a movement how to fill in these gaps, because they're going to get larger and larger, especially for the communities who are in the most need. And that doesn't matter what what state you're in. It's literally going to happen to every community, urban, rural, et cetera. So I'm wondering, in terms of when you were mentioning you talked with an FQHC, do they understand what DPC is, or what is the conversation in terms of you educating them about what DPC is? Because I think this is helpful for people who are, we're on one side of the community. We're always talking DPC, and there's clearly other people in the and not the DPC community yet who are speaking, but we only know how to do insurance. So how are you speaking and how are you educating people who are not always in the DPC space like yourself and myself?
Sure. Well, I feel out what they do know, because it's really, I guess it's not astonishing, because this was me maybe 4 or 5 years ago. I didn't know what DPC was. I didn't have a clue that was even something that could be possible.
Sure.
And then with the FQHC, it's clear that they know very little about the model. And they're so entrenched in the, of course, because they have to be, how to pay for healthcare using government funding and obviously also commercial health plans. And so they are very entrenched in the mechanics of using insurance and government plans to pay for healthcare. So, as my husband noted, there were 12 people at the table in our Zoom call, and probably 11 of them did not practice clinical medicine.
Yeah.
They were administrators. And that's not a knock on them at all. Like, that's the system that they had to set up in order to service thousands and thousands of patients. And thank goodness for them, because otherwise those patients wouldn't get any care.
Yeah.
But it's a very, very different model than DPC. And so they start asking out just extremely basic questions like, how do you even get patients? How do you market to them? How do they know you exist? What do they do? What do you do after hours? And it's like exactly the same questions that I asked when I started mulling this over in my head. And I'm like, wait, what is this beast? I've never seen this before.
Yeah, totally. And, it's so interesting because that's exactly what I was thinking when you were saying that just now. Is like, wow, where did those questions sound? How come it sounds familiar? And I have also been in this place of like, oh, like this is a real thing. I remember going to my first summit only because somebody told me to, and I had zero idea what DPC actually was. And so this is fascinating. And it's exciting too that more people are. It's unfortunate that they're being forced to look into another way, but it's like, what a time to be innovative. And going back to how you mentioned creative ways to offer your DPC offerings to different people in the community, I'm wondering, are you guys coming together as, the region within Louisiana to have more of these conversations? Louisiana is a state. Where are you guys in terms of who in the DPC community in Louisiana is coming to the table to try and brainstorm with people who are not yet in the DPC space?
Yes. So that's actually also been a really exciting sort of recent movement in Louisiana. There's a handful of DPCs, many of whom have been open for over, I would say, 6 or 8 years, who are coming together and forming a coalition. We've already kind of all met for dinner together and had a good time in Baton Rouge and met each other in person. And I don't necessarily know that everybody wants to be part of a coalition.
Sure.
Everyone's in different places in their practice and their lives right now. But there's definitely a handful of people who are looking to start a Louisiana coalition and getting that movement going with the networking. And I met a handful, the DPC Summit 2025 was in New Orleans this past weekend. And I met a couple private practice doctors who were from Metairie, who was that's a suburb of New Orleans, and they were DPC curious. And so we're sort of enveloping them under our wing at the same time. And I don't know where it's going, but just having the fellowship in the first place has been really, really fantastic. I've learned so much from the Louisiana doctors who came before me, and it has been such a privilege to speak to them and work with them and learn from them. And it makes me want to pay it forward.
Yeah, that's awesome. And I think that is literally getting at, what we enjoy with our patients, having a relationship with them. When we have a relationship amongst our own community, that's so powerful, because then, even just by talking out about something like, oh man, I'm really struggling with accessing lidocaine or whatever it is, you don't know, just same as when I talk on the podcast and then somebody randomly will say like, oh, I heard that and it made me move to this different state and open a DPC. Like, we never know who we're going to meet or talk to. But when it comes to working together with all of our different experiences, I think that there's always going to be power in community and coming together to move forward together for the community. So I think that's fantastic that you guys are, even looking at how do we work together. And I will say that this is something that Jake Heath of the DPC Coalition echoed this weekend, is that even though now the HSA legislation has passed the Primary Care Enhancement Act, this is where the work really happens, because as more people are going to be impacted by losing healthcare, as more physicians are going to be replaced by non-physician providers, as more access points physically are going to close, and more people are going to look into DPC because of whatever reason, including necessity, this is where we have to speak up, in my opinion, to make sure we do not rebuild a system that have just left.
Mm-hmm. Yes, absolutely. And then to speak a little bit more to that in terms of the physician empowerment and leadership being as important as it is in this day and age, I'm one of they're called cluster leaders of the Reproductive Health Access Project. So I'm one of the co-cluster leaders in Louisiana. Given that it's a very restrictive state for women's rights, it's actually quite apropos to call us a cluster. We are currently in the process of setting up a group, sort of, I don't want to call it a project, but a meet and greet almost with the Emergency Medicine Reproductive Health Access Project, because as physicians in different specialties and people who care about, in this particular circumstance, it's going to be women's health or human rights when it comes to those who menstruate or bear children, we have got to reach out to whoever we can to help each other. And that's not something I've ever seen before. And I consider myself somebody who's really been in the advocacy space for a long time. And so maybe that's a silver lining. Family medicine doctors and emergency medicine doctors coming together to strategize, because we need all hands on deck right now.
100%. And I will say here that if advocating for our profession, advocating for our patients, advocating for human rights, access to healthcare, all of the things, if that really makes you fired up as you're hearing this, I definitely would say talk to your colleague in DPC, see how, if they've advocated, where have they gone? Local, Chamber of Commerce, City Council, state, federal, where? Because I will say that in general, whether it be local or whether it be federal, I will say that one of the things to keep in mind is that DPC has always been bipartisan, and it remains so in this time of extreme divisiveness. And where we can advocate is literally telling about how we're delivering care to patients, not how we're delivering care with religious beliefs or political affiliation, but literally, this is the access and quality of care that I can deliver to my patient that I have a relationship with over time. And that is quite powerful. And so I say that because even before we started recording, that was a concern that I was hearing, is that how do you advocate if, medically we don't all agree? We're not talking about how we can come together, put our heads together to ensure ways of people accessing healthcare and not health insurance. Thank you so much. It's so wonderful and just fulfilling to know that there is a doctor out there like you who has literally followed her work and her mission and making sure that they tie together at all times. So thank you so much for what you do. And I'm so excited for everyone to hear this.
Thank you. Thank you. You as well. I really appreciate you.
Thanks for tuning in to My DPC Story. If this episode inspired you, please leave a 5-star review on Apple Podcasts. It helps more physicians find these stories when they need them the most. If you're new to DPC or just beginning your journey, head to the Start Here page at mydpcstory.com. I've put together a practical startup guide and highlighted the episodes I think are essential for beginners. Got a question or a challenge you want to hear addressed on the show? Go to the contact page at mydpcstory.com and leave me a voice message. And be sure to check out our My DPC Story Patreon. As a member of our Patreon, you'll find commercial-free episodes and extended versions of the regular episodes. There's something for everyone with both free content and a paid tier that helps support the show. Follow us on socials at MyDPC Story and check us out online at mydpcstory.com. Until next time, this is Marielle Conception.